Good morning. My name is Sheila Zelkowitz. I'm the chair of the Health Committee, and on behalf of the committee, I'm here to welcome Dr. Marc Lipton to do our first talk of this new season, and he's going to talk to us about foot care. Before I get started, I want to say I'm introducing him, but all of the work was done by Renata Solon in getting the speakers, so she's the one we really need to thank. Dr. Lipton may be familiar to some of you because he actually practices here twice a month, and he also works in Columbia and Catonsville, where he's available for office visits. He is a board-certified physician in foot and ankle surgery with more than 24 years of experience. He has been identified as Baltimore Magazine's top doctor in 2016, 17, 18, 19, and 20. That's a pretty good record. So I want to know what happened to 15, but
I can't speak to that.
but you know, in his practice, he does foot surgery. He deals with heel pain, diabetic and vascular foot care, and sports medicine. Probably the sports medicine is not quite what we need, but you never know. We play a lot of pickleball. So, and there are still some of us that need that. The other thing I'd like to mention to him is that he and I are both from New York. You can't do better than getting a Long Island physician to come here. So on behalf of the Health Committee, I'd like to introduce Dr. Lipton.
All right. Thank you for the introduction. You took 10 years off my practice life, and I appreciate that. It's really been closer to 34 years. So, well, you guys asked me to come down here and give a talk, and what I normally like to do is just sort of make it pretty open. So if you have any questions, feel free to interrupt me along the way. I sort of made a pretty broad subject and sort of cover most of the things that I see and treat in the office. And if you see something up there that you have a question on, don't hesitate to ask. Okay. So when I was first starting out, I was in college and I applied to podiatry school, got in and told my mom, and my mom worked for Time Warner Communications, which owned Mad Magazine, and she happened to be in the office of the guy who drew this, Sergio Aragones, who's one of the, he's very well-known artist for Mad Magazine, if you're a fan. And he drew it that day, and Mom brought it home for me, and I still have it. So many people ask, what's a podiatrist? People come into the office, and I work in a large practice full of orthopedic surgeons. We have a plastic surgeon, we have physiatry, and we have myself and another young man who is a podiatrist as well, and they ask, well, are you an orthopedist or are you a podiatrist? What's the difference? And with podiatry, our training is very similar initially, but after the first couple of years of school, we sort of veer off and specialize and concentrate our training only in foot and ankle disorders. Not that we don't learn about the rest of the body, we certainly do. I did rotations in medicine, dermatology, vascular disease, all sorts of different things. So we really get a broad education, but primarily we focus only on foot and ankle. Our licenses are limited to practice in the foot and ankle as well. And so I always tell people we're sort of more like equivalent to an oral surgeon or a dentist in the way that we practice. But I take care of a bunch of different things. Anything, if it's on the foot or ankle, generally we take care of. And I have a broad range of patients, anywhere from infants to older adults. So training, 4 years undergraduate degree. We take the MCATs just like all the other medical professions. Then we go to podiatric medical school, most of which are parts of mainstream medical schools as well, due to a 2 or 3 year hospital-based residency, and then possibly a fellowship. My partner, Dr. Brandow, has done a 3-year residency in the fellowship, so he's done 4 years of training after school, and that seems to be the trend these days. I'm an older guy, and when I was training, 2 years post graduate training was all that was available, and things have really changed a lot over the years. Of course, we're licensed by the state as well to practice. And myself, I went to undergraduate school at the State University of New York at Albany, and then followed by Temple University College of Podiatric Medicine. And then I did my graduate training in Kansas City, of all places, where I met my wife. And then we came back to Maryland. So just a little bit of talk. People ask me, what should I do with my feet? Do I need to come in and see a doctor just to have them checked, like a well patient visit? And the answer is not necessarily. Just take good care, like you would the rest of your body. Don't do anything crazy, no home surgery, that sort of thing. And the most important thing is to observe your feet every day and just make sure there's nothing unusual going on. We'll talk about some common foot problems and things that I see on a day-in, day-out basis in our office: bunions, hammer toes, toenail issues, and diabetic and vascular foot issues. So there are 3 different foot types. There's a flat foot, there's a high arch foot, and there is a normal or neutral shaped foot. So the most common problems that we see are associated with flat feet. And people can get flat feet in a number of ways. Most commonly is it's passed on from one generation to the other, and it's really the shape of the bones and the joints of the foot and the way the tendons function that cause the flat feet. People can develop flat feet as time goes on, and the way this happens is tendons failing to support the arch of the foot, either because they wear out or rupture, so you can have trauma or just wear and tear, and as you grow older, your foot can get flatter and flatter, and that in and of itself presents a number of problems like tendinitis or chronic fatigue and pain. So flat feet are very important. And people who have them as when they're younger don't necessarily have any problems associated with them, but as they grow older, it certainly could lead to issues and impairing your ability to stand and walk for long periods of time, and chronic pain. And there are various things that we do to treat, and maybe we'll show you a little bit later, different types of things that we can put in the shoes to support the foot, bracing, even surgical correction. So just wanted to mention that a little bit. So flat foot, it's the foot that has no arch. And if you look at the footprint, you can see when you have a normal arch over here, your foot is not fully contacting the weight-bearing surface. With a flat foot, the foot fully contacts the weight-bearing surface, and that causes lots of issues: callousing on the bottom of the foot from increased weight-bearing, and then fatigue of the tendons that are trying to pull up that arch. So there are a lot of pathological conditions that can occur from a flat foot. Some people go their whole life, no problem with it, but there's a certain segment of the population that has flat feet, and as they grow older, it can become more and more problematic. So again, just sort of depicting a normal foot versus a flat foot where the arch is lost, the arch is maintained in a normal foot, and then the next iteration is a very high arch foot. And I think that's sort of a misnomer, claw foot. We call it a cavus foot, really. and this is depicting a cavus foot, which is very high arch foot as compared to a normal arch foot. And what's the difference with a flat foot? I like to describe a flat foot as well as a very broken shock absorber in the car. So when you hit every bump, you feel every shock. And that causes problems not only in the foot, but in the knee, the hip, the low back. So the shape of the foot is very important with how the rest of you feels. In a high arch foot, I describe that as a foot as a very stiff shock absorber. So also feeling every bump in the road, but just the foot just isn't giving enough, and that presents its own problems. High arch feet are much, much less common than flat feet. High arch feet, if you're born with them, it's congenital, and that's about 33% of the people who have high arch feet are born with them. The overwhelming majority of people with these high arch feet develop them over their lifetime, and it's often related to neuromuscular diseases. Any disorder that causes the muscles and tendons not to work correctly can have the ability to cause a high arch foot. And one of the ones I can think of offhand, Charcot-Marie tooth disease, the hallmark is a high arch foot from paralysis of some of the muscles in the lower extremity. So you may never have heard of that, but high arch feet are just much less common, but have problems associated with them that we need to be aware of. And then the most common problem I see, bunions. Bunions are a enlargement of the first metatarsal head, and then I'll show you on our next slide what it looks like on the inside, but the great toe migrates over toward the fifth toe, and it causes this big prominence of bone over here. And that causes difficulty with wearing shoes. You can get irritations there, callousing. You can get arthritis in the big toe joint. You can have problems because the big toe pushes up against the second toe. It makes it difficult to wear certain shoes. Standing and walking can be very uncomfortable. And bunions are more associated with flat feet as well. So this is just an x-ray, and you see how the other bones in the foot are nice and parallel to one another. And when you have a bunion, the first metatarsal deviates out, and you see that enlargement of bone over there and the soft tissue bump, and then the big toe drifting over to the fifth toe. So that's what it looks like inside the foot when you have a bunion. And a lot of people, they do develop arthritis right at that joint over there, and it's very painful. Just showing a mega bunion there. Just from rubbing in the shoe, this person had callousing over the bump, and you can see how hard it would be to wear a shoe or walk. Also, lots of arthritis in the joint over here, and very difficult to bend that toe up and down. It can be very painful. A lot of people have bunions, no problems their whole life. It's more commonly seen in women than men. Men, even when they have it, don't seem to have as many problems because we wear different shoes that may be a little bit wider, and women wear more variety of shoes, and lots of them are narrow in the forefoot, and that could be cause of symptoms. In my profession, we don't really feel that shoes are caused or are the cause of bunions. We feel that shoes aggravate bunions. Bunions are going to happen no matter what. If you have a flat foot or a foot prone to bunions, you inherit you inherit that, and the pain associated with bunions can be caused by improper fitting shoes. And one of the ways to treat bunions is to wear a shoe with a wider toe box, wonder if I have that next. Oh, just another picture of a bunion. And the other thing I didn't mention is the bunion can be so severe it can undermine the toes and create quite a big deformity. Once it starts pushing the second toe up, then you start getting pain over here, pain over here. It's a very uncomfortable problem, but very, very, very common. And just a depiction of another severe bunion, and you can see the hammer toe over here. We'll talk a little bit about that in a bit. Okay, again, bunions can be surgically corrected. We have many, many different operations, developing new procedures and techniques. Every year, I think something new comes out, but just want to show you a before and after picture of how severe the deformity could be, but corrected simply by cutting and repositioning bone in the foot, using screws or staples or different types of hardware to hold the bone in position, and getting a very good result. You can see how that would be a lot easier to fit into a shoe than that. Bunion surgery is not horrible. We all hear of stories of people who've had horrible problems and pain after bunion surgery. By and large, most people, the overwhelming majority of people, do very well, have a quick recovery, and seem to be very happy with their decision to have bunion surgery. The biggest problems associated with having foot surgery are it's your foot, and you need it to stand and walk, and it does cut into your ability to do that for a number of weeks or even months for healing purposes. If it's your right foot, you have difficulty with driving. So it's not like getting a hand operated on or an arm where you can put it in a sling and move around. There are some lots of problems with disability because of the location of the surgery, but by and large, most people heal and do really well from these type of things. So treatment depends on the person, depends how active you are, age, and overall health, and if it hurts. And what I ask most people is, who are contemplating bunion surgery or even, treating it is, well, how's it feel? We don't really care how it looks, we really care how it feels. If there's no pain, you're able to do your day-to-day activities, you're able to stand and walk comfortably, and then there's really no reason to do much of anything about it except to avoid things that could aggravate it, like wear comfortable fitting shoes and just avoid anything that will irritate it. And for most people, that's fine. But if you can't wear your shoes, you can't do your day-to-day activities, you're having constant pain, then that's the time to treat it. And treatment could vary anywhere, as I said, from surgery to devices to wear in the shoes to take pressure off of the bunion, or wearing a shoe with a wider toe box to make yourself more comfortable. Nowadays, there's a lot of good shoes out there, and it's easier to find a shoe than it used to be that to make your life easier. So you don't necessarily have to have surgery. Cortisone shots sometimes are helpful, but for most of these, we can treat either non-surgically and, in the worst cases, in the appropriate person, surgically. Just another example of a relatively simple surgery to correct the bunion. We just basically shave the bump of bone, cut and reposition the bone. We put a little screw in to hold it in position, and the bump is essentially gone. These type of surgeries take 6 to 8 weeks to heal, and most people are back in the shoe by 8 weeks. Just a little more complicated procedure, just showing correction of not only the bunion, but an associated hammer toe. Bunions and hammer toes like to travel together. And just another picture depicting a correction of a bunion. What are orthotics? I may frequently mention these. They're devices that you wear inside of a shoe. They're prescription devices often because they can be custom made. They fit the shape of your foot. They correct for different types of foot deformities like flat feet, high arch foot, and they can be helpful in offloading bunions and various other conditions. Hammer toes, that's another common problem we see and often associated with a bunion. Hammer toes are basically a buckling of the toe or a contracture of the toe at the joint right over here, and then also at the joint right over here. This is called the MTP joint. This is called the PIP joint. And it can be caused by arthritis. It could be caused by trauma. It does develop slowly over time. And as you can see, it makes wearing shoes difficult. Oftentimes, we'll get an irritation at the top of the toe called a corn. Sometimes we can treat that just simply by trimming it down, putting pads on the area, wearing a shoe with a deeper toe box so there's more room from the top to the bottom of the shoe. And sometimes we like to correct these surgically. So some simple things that we can do are splint the toe down in position, wear a shoe with a deeper toe box, or surgically straighten the toe by removing a small piece of bone. And just some picture depicting surgery. We use pins to hold the toe in position after we've corrected it. But nowadays, we are able to replace the pin with a new implant that goes into the toe itself to hold the toe into position. So so we've gone from this to this over the past few years. The advantage of this is that you don't have anything sticking out the end of the toe that needs to be removed. The disadvantage of this, it's very expensive. These can cost hundreds of dollars, while this wire that holds the toe in position, I think it costs $6 or $8. So this works well. It works very well. But this is nicer. It's less possibility of infection and even a quicker recovery time. So we have made some advances over the years, but we still do it this way for many people. If insurance doesn't cover the implant, or it's patient preference as well. But as you can see, this is a much easier way to go. Again, another picture of a hammer toe. You can see why that's a problem. One thing I probably didn't mention, and we talked a little bit about corns. Corns and calluses are the same thing. We call corns when they appear on toes, and calluses when they appear on the bottom of the foot. Callus is just an area of irritation, or a corn is an area of irritation. The skin responds by getting thick, and it protects that area, but sometimes the thickening can become so severe that it causes pain, and for a lot of people, we just trim them down in the office. We wear appropriate shoes and insoles, and that seems to take pressure off of those areas and be helpful. And this is an example of a high arch foot, or a cavus foot also. Toenail problems. They do look horrible, but we see them every day. I see them every day. This is most likely caused by a fungus. And why do they get so long? They get so long and thick like that because people can't take care of them. It's very difficult to trim them at home. And people sort of let them go, and it becomes difficult to wear shoes. It becomes unsightly, and it becomes difficult to perform normal foot hygiene. And that's when I see people in the office for this. Fungal toenails can be treated any one of a number of ways. We can treat it simply by keeping the nails trimmed back, and that takes away the pain, that makes it more comfortable, but it doesn't cure the fungus. We do have medicines. I don't know if I have. Yeah, we do have medicines to treat fungus in the toenails. The most effective way of treating it is with a pill. The problem with pills is that they can interact with other medications you may be taking. We need to monitor liver functions while you're on those medications, because there is a possibility it can affect the way the liver functions. By and large, it's very safe and very effective. It works 75 to 80% of the time to clear the fungus. The problem is a fungus is an infection, and we can clear it up, and then 2 years later you can pick it up again. So it's a very pesky type of thing that we treat. We see it every day, and to be honest, as people grow older, we end up doing the what's called palliative care, which is trimming them back, and that's an excellent way of keeping people comfortable walking and able to wear shoes. Any questions so far? Okay, I'll keep going. Okay. Ingrown nails, another common condition that we see, and there are lots of different causes for ingrown toenails: trauma, chronic pressure on the toe, improper trimming, or inherited. And you can inherit the shape of a toenail that can cause ingrown nails. But I think the most common thing is repetitive pressure from improper fitting shoes or improper trimming as a cause of ingrown nails. In kids, we see kids all the time with ingrown nails, and we're more likely to see that type of situation where there's swelling and infection and drainage in a younger person. And as we get older, we don't usually let it get to that point. This is normally my 16-year-old patient who comes in and forgot to tell mom that they have a problem. Mom sees the sock, it's got bloody drainage on it, and brings the patient in. But as we get older, we get a little bit smarter, and when our foot hurts, we say, something's not right here, and take a look at it. And a lot of people trim them out themselves, or they come in to have us trim them out. But we do have procedures where if just simply trimming them out isn't enough, we have procedures where we can remove the ingrown nail permanently. Doesn't work 100% of the time, but most of the time we can resolve the problem permanently. Just a close-up view of how severe the infection can get, and you can see how red it is all around there. You can get redness going up into the foot. Something like this we have to treat with antibiotics and removing the ingrown portion of the nail. Okay. Common things we see also, blisters. There's a lot of different reasons why people get blisters. Now the most common reason I'm seeing it is because people are out there walking. Why? Because they're home because of the pandemic, and they've got time and other things they want to do. They want to work on their health and doing a lot more walking. The most common cause of blisters on the foot is improper fitting shoes or wearing shoes without socks. And we see that a lot. What's the problem with getting blisters? Usually it's not a big deal, but as we grow older, our circulation isn't as good as it used to be. And if you get an infection or a wound, it may be more difficult to heal. So we want to prevent blisters as much as possible. The best way to prevent it is to wear a good fitting, comfortable shoe with a good sock. There are lots of other reasons you can get blisters on the foot, burns or allergic reactions, but the most common thing we see is simply rubbing in the shoe. This becomes a problem when people with diabetes who don't often feel the bottom of their foot because of something called neuropathy, and we'll touch on that a little bit later. When you can't feel your foot, small problems can become big problems very, very quickly. They can become infected. They could have problems with healing, and people can end up with serious issues and even hospitalization and loss of their foot. So we want to pay close attention even to the simple things. And that brings me into just a little bit about diabetes. A large part of my practice is treating people with complications associated with diabetes. Um, People with diabetes are more prone to poor circulation, and that's called peripheral vascular disease, or loss of sensation in feet, that's called neuropathy. And those two things lead to lots of problems. So we do recommend that people with diabetes be seen by a podiatrist once a year if they have no problems, and more often if they do. A lot of times your primary care physician will recommend that you do things if you're diabetic once a year, get your feet checked, get your eyes checked, go see your dentist, and follow with your medical doctor on a regular basis, because diabetes affects the whole body. My concentration is in the foot, and the things that I'm concerned about are problems with wound healing, problems with toenails and skin, and we want to avoid infections. We want to avoid people needing surgery and hospitalization. So people with diabetes have a greater risk for foot ulcers. What are foot ulcers? They're wounds on the foot that do not heal. So something like a blister, if you can't feel it and you have poor circulation, could develop into a foot ulcer. Just rubbing in the shoe, if you have an improper fitting shoe, can cause a foot ulcer. As we grow older, the skin is a little bit thinner. It's a little bit drier. Doesn't have as good blood flow, and it's more likely to break down. People with diabetes have an altered immunity, and when you do get an infection, it's harder to fight it off. Even if your blood sugar control is good, there are lots of chemical things going on in your system that makes it more difficult to fight off infections. When infection spreads from the skin deeper into the bone, it becomes a real problem, and uncontrolled infection can lead to death. People with diabetes who develop wounds on their foot or even amputations are at a much higher risk for death than people who do not have wounds on their foot. The number of hospitalizations for people with diabetes and infections and amputations is the past few months, because of the pandemic, actually skyrocketing, because people did not seek care early on in the pandemic, and we're seeing people who are sicker and having more severe problems than maybe they ordinarily would have. People with diabetes have heart disease and generalized vascular disease as well, and that's an issue. So when we treat people with diabetes, the number one thing we want them to do is to make sure their blood sugars are controlled. My goal is to prevent problems, and that's why I see people in my office every 3 months, every 2.5 months or so, just to not just to trim their nails, but to examine their feet. And I think that's a good way of preventing problems. Always wear shoes, always protect your feet. Avoid temperature extremes, and we're coming up to the winter now, and it's very, very important that if you can't feel your feet, you have to dress for the weather. Hopefully you're not outside for an extended period of time in cold weather, but you just have to be wary about that. If you have a cut or a sore on your foot, if it's lasting more than a few days, doesn't seem to be healing, you need to have it looked at. Anything red hot or swollen in your foot, don't, and this goes for everyone, this is not just for diabetes, don't ignore problems, just have it looked at. I'd rather see someone in the office for 5 minutes and say, oh, it's nothing, than have them ignore something and end up with a really severe problem and end up hospitalized. It's a lot easier for me, it's a lot easier for the patient. And prevention, For diabetics, as I said, we like to see them at least yearly and check their sensation, check their blood supply, take a look at the shoes. And you may not think I'm sitting there trimming toenails. I am looking at all those things, and it really, a 5-minute exam really can prevent problems in the future. And again, not necessarily just for people with diabetes, people with vascular disease or with other systemic conditions that can affect the blood flow into the foot. And if you can't get to your podiatrist, mention it to your medical doctor. But if you can't see your own feet, have someone look at your feet for you. If you have trouble getting to the bottom of your foot, a mirror is a good way to look at the bottom of your foot. But just a very important thing that we do as podiatrists. And we don't want, sorry for the horrible picture, but we don't want your feet to look like that or a severe infection like that. And these are the things that we try to avoid. Unfortunately, these are things I see all the time. So we brief mention about shoes. We're fortunate nowadays that there are a lot of great shoes out there. And a lot of people are concerned with how the shoes look. They are getting better every year. They're coming out with better and better shoes that I think look pretty good and are better for your feet. We want to avoid the really thin, flimsy shoes, if at all possible, for a day-in, day-out shoe. We want to avoid flip-flop sandals, if possible. And we want the feet to be protected and supported. So shoes are very important, and we do have to be careful with them. And now I'm here for the question part. So, pretty good. Yes?
Hold on. Bunny, will you give me 1 second? So anyone who is watching live online, if you would like to call in to have any questions answered, 410-696-6768, and I will answer the phone and repeat the question to Dr. Lipton. Thank you. And now I come to you.
What was I going to ask? Oh, is there anything that you can put on toes to soften them at all? My husband's they're so hard that I have to use one of his tools to cut them. I can't do it with a regular clipper.
Right, you're talking about the toenails. So, yeah, there are some products out there. There is a product called urea cream that you can buy over the counter, 20% urea cream. And it's just a cream. You can put it on the nails once a day. I usually tell people to put it on at bedtime. Put the socks on, and it will help soften the toenails. And there's another product over the counter called Kerasal, Kerasal. And that is pretty helpful in softening the toenails and taking out some of the discoloration. Soaking the feet, that's not something we recommend routinely, especially for people with diabetes, because soaking can cause extra moisture. That can cause fungal infections. If the water's too hot and you can't really feel it very well, it can cause a burn. But you know, people soak to soften the nails before trimming them, and I don't normally recommend that. But I think one of those two products is pretty good at helping to soften the nail, make it a little bit easier to trim. Nail files work pretty well too. It makes it easier. You can now. Maybe we need to see him. Yes, ma'am.
What is you said there's a tablet for the fungus. What is it?
Well, there are lots of different medications. The one I use most commonly is called terbinafine. Well, the trade name is Lamisil. That's easier to spell. Lamisil, Lamasil, or terbinafine is Terbinafine. Terbinafine, yeah. I'm better at spelling when I can write it down. But there are other drugs out there. There's a drug that I use occasionally called diflucan. And they're taken different ways. They all do about the same thing. And they all work pretty well, but they, if people are on different medications, if you're on drugs like Coumadin or Xarelto, blood thinners, we have to be really careful about that. These medications can interfere with other medicines. We always do lab testing when we're on these medications. There are topicals. There are some newer topicals that are prescription strength. They're very expensive. They're hard to get approval for, and they work minimally better than over-the-counter medications. Some over-the-counter medications can be helpful. It just depends on how severe the infection is. When it's first starting, over-the-counter medicines and even the prescription topicals do work. But when the whole nail is involved, like the picture I showed you, that's when we have to go to oral medicines. There are other treatments as well, like lasers. I have found lasers can be helpful in conjunction with topical medicines. The problem with laser therapy is it's not covered by insurance and can be expensive, and also is not as effective as the oral medications. Yes?
What does, as far as Medicare is concerned, what doesn't it cover in foot care?
It does not cover routine foot care. Routine foot care is considered the cutting of toenails and corns and calluses in the absence of a qualifying systemic condition. So what's a qualifying systemic condition? Diabetes, peripheral vascular disease, when the toenails are causing pain and causing difficulty wearing shoes, standing and walking, or they're interfering with your ability to walk. So painful gait, pain often is a reason they will cover foot care. So people generally that I'm seeing that are getting their nails cut where it's covered have an underlying condition like diabetes or vascular disease, and that, or pain associated with the toenails. Painful ingrown nail, that sort of thing will be covered. They do not cover orthotics. They will cover diabetic shoes and insoles in certain conditions, but the Medicare will cover most foot problems if they are associated with pain also. They don't cover treatment of flat feet. They don't cover treatment of warts. They do have a lot of exclusions, but they will cover most things if there's pain associated with them.
What about a corn between the large toe and the toe next?
So if it's causing pain, difficulty with wearing shoes, there's an underlying deformity, they will in all likelihood cover a visit to be evaluated and treated. If you come in, if you're in good health, you have good circulation, you have no underlying systemic conditions, then if you come in periodically just to have the corn trimmed, they may not cover that visit. But if you're coming in for treatment to relieve pain, that sort of thing, it may be covered.
You need a referral?
For Medicare, you do not.
Could you talk about neuropathy not associated with diabetes?
I can. Neuropathy is not necessarily in the realm of diabetics only. People can develop neuropathy for many reasons, and the list of reasons is about that long. Okay, it could be chemical exposure, it could be medication related, but outside of it could be spine related if you have a spinal condition, but most people who have neuropathy who are not diabetic that I see have what's called idiopathic peripheral neuropathy. And idiopathic means we don't know what caused it. We don't know yet what caused it. We'll figure it out one day. Or someone smarter than me will figure it out one day. But it could be the same as diabetic neuropathy, which is a whole lecture into and of itself. We have two different types of neuropathy. We have painful neuropathy, and we have painless neuropathy. The one that I'm mostly concerned about is painless neuropathy, because you figure, well, there's no pain, it's not bad. But no pain means numbness, and numbness means you can't feel what's going on with your foot. And if you don't feel a problem with your foot, then there's no problem. And that's what I see all the time. There's people who maybe had a blister or an ingrown nail. It didn't hurt. It didn't cause any problems. Next thing you know, they have a fever. They have chills. They're sick, and they're in the emergency room. So we don't like the painless neuropathy. We really are concerned about those people. We really want to see them frequently just to make sure there are no problems, trim their nails, make sure their shoes are good. And this goes for people with neuropathy not caused by diabetes. The other type of neuropathy is painful neuropathy. Painful neuropathy is uncomfortable, but most people still have sensation in their feet. There are medications that can be helpful to treat the painful kind of neuropathy, but we do not have a cure for it, unfortunately.
Cutting nails.
Yes.
I've heard you shouldn't cut them around. You should cut them straight across. Is that right, or does it make a difference?
So the general thinking is to cut toenails straight across, even with the end of the toe. And what I usually tell most people is just to follow the contour of the toe. So there may be a little bit of of a curvature. I don't like those sharp corners like that, because they dig into the side of the toe. So we like just a gentle curve to it, even with the end of the toe. And the toenails grow very slowly. And as we grow older, our circulation to our foot is not as good as it used to be. We need blood flow for toenails to grow, right? Because it's, it has to be well nourished. And the less blood flow, the slower the toenails grow. The skin gets thinner, you start losing hair because your blood flow isn't as good as it used to be into the foot. We just have to make sure we keep the nails trimmed on a regular basis. When you're 20 years old, you have to do it every 2 weeks. When you're 70 years old, maybe every 2 or 3 months is enough.
Okay, I have another question.
Sure.
As everybody around here knows, I don't wear shoes except if I go outside or to dinner. And I've found over the years that I fall or almost fall a lot more. Well, I've never fallen in my stocking feet, but
Okay.
I have almost fallen or fallen with my shoes on because maybe my one foot sideways a little. So I don't know if it gets, I don't pick it up enough and I go just forward. Am I hurting myself because my feet don't hurt?
Well, I mean, when man was first came around, we had no shoes, right? We were meant to walk barefoot, but we've had to adapt to the environment. And the major reason we wear shoes is because of the outside environment, right? So yeah, you do have to be careful. Are you doing any harm? I think if your feet are comfortable, you're not having any pain, and you're not falling, I think it's probably okay. I think why do people fall when if you have a drop foot or some weakness in the foot and you're not able to lift your foot as far as you can, then it's easy to trip. And you may be having some sort of issue like that, and you just feel more comfortable and you're used to it. So for most people, I'm going to tell them to wear shoes. So. That's it? All right. You're welcome.